over that 15 minutes, forget it, it's hard to flip. Okay, diabetes, this is going to be where we end today. So let's just review diabetes type 1, type 2. What is the difference, and why are we seeing such an increased incidence of type 2 diabetes? That's right, obesity. When there are more fat cells, it makes the insulin harder to work. It actually puts more pressure on the pancreas, so it becomes a physiological, or over time, the pancreas, not that it can't release the insulin, but it's not as effective in what it's releasing. So sometimes we can try other methods like losing weight, diet, exercise at certain point, kind of modifying things, and also oral medications with type 2 diabetes. Type 1 diabetes is purely the pancreas non-functioning, and then it no longer can, it does not release the insulin, therefore you need synthetic insulin. Okay, that's the type 1. What is starting to happen with diabetes is that young children, when they get diabetes type 2, it mimics diabetes type 1. So that even though it's truly a type 2 diabetes, it presents like type 1 where they need to have the synthetic insulin immediately. Because they're so young that the pancreas was still immature in its development to begin with. So with adults, we can actually sometimes work with this and be able to get their weight down, and they can be able to manage it with diet and exercise, and even with oral anti-glycemic agents. But it becomes harder when you have a child who is overweight and then ends up with diabetes. It becomes more of like a type 1. Does that make sense? And then you get the diabetic ketoacidosis with it and everything else. Because I've had students say to me, how are they getting diabetic ketoacidosis with type 2 diabetes? Well, because their type 2 is more like a type 1. The people who do have type 1 diabetes, some of it is thought to be an immunologic response, and some of it is genetic, like it runs in their family. They have cousins or people that have type 1. They usually don't have weight. It has nothing to do with weight, obviously. And again, when you have an insulin deficiency, whether it's type 1 or type 2, basically you have impaired metabolism of fats, carbohydrates, and proteins because you are not able to use your sugar. So when you're not able to use the sugar, then you have impaired metabolism of these, which break down, and you get hyperglycemia, which that hyperglycemia, which is leading to a cellular starvation, which because it's not in the cells, it's actually outside extracellular space, can actually lead to those things like polydipsia, polyuria, polyphagia that we talk about, right? Those 3 Ps, right, which you're probably familiar with, the excessive thirst, excessive eating, and excessive urination, because you have that cellular starvation that's occurring. And again, you have an unnatural balance because you start to break down the proteins and fats, so then you have ketones that become excessive, and then that also can shift more fluids away from the cells, causing more of the polyuria and things like this. And so producing in response to cellular starvation because you're breaking down the protein so much that you're increasing your ketones, which is the breakdown there. And you end up with a ketoacidosis. Type 2, again, as we said, is increasing. And obviously there's risk factors with type 2 even too, of being in the family. Does people who are overweight who have a family history of diabetes, type 2 are more likely to develop this also. High cholesterol, and again, insulin levels of all children who are considered overweight or obese should be assessed. So you see very similar, polyphagia, polyuria, fatigue, malaise, headaches, because again, they're not getting the proper absorption of nutrients. The criteria for children, which I don't think is too different from adults, is you have a fasting blood sugar of greater than 120 or random blood sugar of greater than 160. Usually they do a few blood sugar tests, but those are pretty much indicative. If they're consistently that way, that's indicative of a blood sugar issue or diabetes issue. They also do now, do you guys remember what the other test is that they look at that tells you the 3-month range? A1C. That's right, the A1C. And that will tell them pretty much a 2 to 3 month range of how they've kept their blood sugar in level. Because somebody could be great at maintaining it at short periods of time, but it's over a longer time that you want to look at it too, which has a better prognosis if they're able to keep those levels down. So you want to sustain health, promote growth, independence in the management of the condition, and a multidisciplinary approach. So what can a child do if they have diabetes, either type, and at what age? That's kind of what we focus on here too. So by 7 or 8, they should be able, really you want them to understand the disease process because it is chronic from the beginning. By 7 or 8 years of age, they should be recording their blood glucose in books because they would understand numbers at that point and ranges of those. between 8 and 10, they can perform the blood glucose testing themselves. By 12 to 14, they can administer the insulin, and by 15 to 17, they can actually draw it up based off of a sliding scale. And many don't even, some of them are not even using sliding scales anymore. Some are using insulin maintenance pumps that are implantable pumps that are releasing the insulin periodically. Some are on set schedules with the insulin. So the sliding scales are becoming somewhat of a thing of the past in pediatrics anyway. We're seeing a lot of implantable pumps too. They're very popular. They allow for a lot of, the person's pretty active and able to move around and not, and they still checking their blood sugar, but pretty much allows for a lot of mobility with them too, and flexibility.
That's where they have the little device that they around on them.
It looks like a beeper almost.
Yes, I made that mistake before I started nursing school. I'm like, you still have a beeper? And they're like, I'm a diabetic. I'm like, huh. I'm sorry.
We'll make that mistake again.
Yeah, I won't do that anymore.
That's right. That's right. I still find though, and I was gonna, that was something I wanted to check on last semester. I still find that in the hospital anyway, we're still checking it. I mean, I guess because to compare against the pump. But I had a patient that told me last semester, they were like, oh, I check it myself. Also, on top of it, like, I don't know if it's as a way to check it, because I thought the same thing. I'm like, I have a pump, why are you? They do.
I know
You're
that
right.
I have a friend that has it and eventually will die and she'll know, like, if it's not reading
Or
right.
there's leads that could become dislodged. I know that's another problem that can happen, especially for children because they grow so quickly. When they're going through growth spurts, they always have to adjust the leads or adjust something or check on it. So I think that's why some of them still do, and some of the patients I've had still do check their own too. But, and I know we do in the hospital for them, but you're right, in essence, it is checking their blood along with administering the appropriate doses of insulin that they need. And again, just remember, usually insulin is 3 injections per day, an immediate acting with a rapid acting before breakfast, rapid acting before the evening meal, and intermediate acting before bed. Withdraw the short acting first when you have 2 types. That's kind of, Insulin is a cool, dry place. Obviously refrigerated can